Hello, Teresa. This patient likely has iron deficiency anemia, commonly referred to as ADA, with the symptoms of fatigue, weakness, irritability, difficulty concentrating, shortness of breath, and pallor, as well as the laboratory findings that I'm about to go over. Low hemoglobin and low hematocrit are indicative of anemia. Low ferritin, which is a key findings indicating low iron store. High total iron binding capacity of 350 microgram per dl, which is typically elevated in iron deficiency anemia due to increased production of transferase in response to iron deficiency. Normal reticulous count of 1% indicates that the bone marrow response is not increased, which is expected in iron deficiency. There are other steps that can be taken to confirm the diagnosis of iron deficiency. Example, like a peripheral blood smear, which may show hypochromic, microchromic red blood cells, although early IDA can still have normocytic red blood cells. Given his age, it is also important to evaluate him for chronic blood loss through the use of NSAID or through GI bleeding. And so you can also do a fecal occult blood test or colonoscopy. Kidney function test can also be done to evaluate, to make sure that the kidney are secreting a hormone called erythropoietin, which is needed to synthesize and make red blood cells. Dietary intake can also be assessed. His fast food diet with limited fruit and vegetables suggests poor nutritional intake can be a contributing factor to his iron deficiency anemia. Sickle cell anemia is a genetic disorder that affects the red blood cell shape and function, and is quite different from iron deficiency anemia, even though people with sickle cell anemia can also have iron deficiency anemia. There are several ways of managing iron deficiency, including oral iron sulfate. Typically, the dose is 325 mg once or twice daily with vitamin C to enhance absorption. Please, it is advisable to take this medication on an empty stomach if tolerated, and monitor for side effects of constipation, nausea, and black stool. Another way of managing iron deficiency is dietary counseling, where we typically encourage patients to eat food that are rich in iron, example like lean meat, leafy vegetables, beans, nuts, and iron-fortified cereal. It is very important to encourage patients to improve vitamin C intake, which include food like oranges, tomatoes, to enhance iron absorption. It is also advisable to encourage patients to reduce inhibitors for iron absorption, example like excessive dairy, tea, or coffee. Patient needed to reassess in 4 to 6 weeks, where hemoglobin and ferritin levels will be repeated. If there's no improvement, you may have to reassess compliance and consider further evaluation for possible malabsorptions, example if the patient has celiac disease or H. pylori infection. And finally, it is a good idea to investigate the underlying cause. For example, if there's GI bleeding is suspected, then the patient needs to be referred to an endoscopy or colonoscopy. If unexplained weight loss or other concerning symptoms arise, consider further malignancy screening. In conclusion, this patient most likely has iron deficiency due to poor dietary intake and possibly undiagnosed chronic blood loss. Early treatment with iron supplement and dietary modification is a key, but further workup may be necessary or needed depending on the response to the therapy.